The following podcast is not relating to my teachings and work at Delcine Medical Center and is for entertainment purposes only.
Hello, everybody. Welcome to another episode of Life of Flow. Today, we have two good friends of the podcast and mentors of ours too. Dr. Robert Beasley. He's an interventional radiologist at Palm Vascular Centers in the Fort Lauderdale area. And we also have Jan Skowronski, who is the Director of Endovascular Therapies with Cardiovascular Associates in Birmingham, Alabama. And together with myself and Miguel Lichtenberg, we decided to endeavor on probably one of the first ever digital-only educational events for endovascular therapies. The name of this event is Pegasus Endovascular. And I invite you all to join to this event. It's a free event. It's April 20th, 2024 of this year, of course. And the webpage, if you want a little more information, is hmpglobalevents.com/Pegasus. And we invited Bob and Jan to, talk to us a little bit about the event, about the progression of education. And then, like everything in this podcast is just derailed into this.
It took a hard left.
This tangential conversation about professionalism and political issues, and I think you'll find it fun and intriguing. And if you wait till the very end, you'll find a very inviting message from Dr. Beasley to all of the participants for the April 20th, 2024 event. Stick around. I think you'll enjoy it.
Vamos.
Vámonos. Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Are you avoiding showing your legs because of varicose veins? Worry no more. At Hope Vascular and Podiatry, we have the solution. Our vascular specialists are ready to rid you of those pesky varicose veins. Regain your confidence and enjoy life without complexes. Call 346-400-4673 or visit our website at www.hcic.io. Because at Hope Vascular and Podiatry, the new normal is you better.
It's going to be very exciting to have this conversation. And I guess what we wanted to talk about today, a few high-level items and maybe some juicy items towards the end of the show, but it really is about how education is changing, how I would say that in medicine, as with everything, we are consuming information in very different ways. Technology has plagued the way that we take in the information, and I think inevitably this has to permeate the scientific corner, right? And, Jan and Bob and myself, Lucas, you're a little bit younger, but man, we've been doing this for years. I mean, we've been going to meetings after meetings. Every year there seem to be new meetings. And it's almost to the point that I feel meeting exhaustion, right? Mm-hmm. There's just, and I remember, here's the preface how my wife said it when she and I started dating and she came to a few. She looked at me once and she's like, so let me summarize you guys. It's the same guys talking about the same topics all over the world. And I looked at her and I was like, yeah, it pretty much sums it up. That's what we do, right? Yeah. And it does, you do realize that is very antique, right? I mean, that's antiquated. I don't understand that is A, financially feasible, and B, that we're going to continue to have the effect that we had the last 20 years of education. Yeah. So, Jan, I'm gonna invite you here first. Tell me your thoughts about this. Tell me your thoughts about where do you think scientific events go? Yes, there may be some of them that are, our classics, our VEITH or NCVH or these kind of classics, but and those probably will stay because everybody probably needs that. But what's your thoughts here on where we're going, where we're coming?
Thank you. Nice, good to see you and hear you guys. So first of all, I'll give you a simple example. When all of us were in medical schools, we were all equipped with these huge books that we studied. My son is 16, and don't get me wrong, he's a really strong student. He doesn't have a single book to study from. It's all on online programs. Also, he learns from YouTube, he learns from Instagram, and so on. So, if we want to educate the next generation of strong operators, good luck giving them long lectures that take 45 minutes from a podium speaker that talks about 3 years outcomes of drug-coated balloons or learning from books. It's just not sustainable anymore. And so that's my first comment. My second comment is I think with this rapidly changing media environment, some of it is already getting into medicine pretty quickly, and people want to learn from information that is fast, to the point, and in our specialty, mostly case-based. So I'll stop because I have a tendency to talk too long.
So,
So I'm trying to be in 2024, not in 2000. Thank you.
Jan, who's your, for lack of a better word, your client? Are you talking about who's the person you want to educate? Is it somebody that's out of training or in training? Because I think those are two very different people with very different needs.
I don't think so. I think this is the same group. We will talk about the conference that Bob, Miguel, Michael Nuchtenberg, and I will have next month called Pegasus Endovascular, and our audience is global. If we can come up with an attractive product online and educate operators, young, old, mid-career, doesn't matter, the better. So the audience is global, and it's basically all ages, all stages of a career. Thank you.
The what I would push back on that is that I feel like they have different needs, because like we were just this week, we were discussing residents, and I imagine the same thing for fellows. They have their goal is to pass their exam, and how that exam is, and that exam is not usually case based, or it has other necessities which will probably be difficult to include or to like approach through a conference. I mean, for the person that's after training, I think that there is a need for education, for continuous education that is poorly met, and I completely agree with what you're saying. But just because like the residents and then the program directors are just measured, what success is measured in a different way. What success is for the resident is passing their boards, and the successor you're passing the boards. So you have to that's not the same as patient care.
Okay, I disagree. I completely disagree. If your mom one day will require a stent in the heart or a carotid stent or has occluded artery somewhere in the body, you talk to the doctor who's going to do the procedure. You're not going to ask him or her how high the doctor scored on board exams. You will be asking how many cases this operator of this kind has done, and you will be calling around whether this person is a good operator or a poor operator, and there's plenty of them. And so we are just trying to improve endovascular skills for people, for operators of all ages. And exams, well, you have to put your V's next to the B or C or D. We've all done it.
Yeah,
Can I jump in, guys, and just
yeah,
jump
Bob,
in for just a
by all,
second?
Yeah,
by all
please.
means, Bob, by all means.
And kind of dovetail on what Jan started with originally about this conference. I mean, Pegasus is an offshoot of Icarus, which was Jan's baby in Poland, and it's an entertainment, educational event. We're going to get there, and we're going to stimulate conversation as well as controversy during this meeting, and we're going to have Miguel sitting there. Miguel's going to pointedly ask some of these surgeons, why are you going to be doing a carotid, not a carotid, but an endarterectomy on a common femoral when you can put a stent, and a stent's going to stay open for a while or longer than that. I mean, this is the things that we're going to bring out, and I think we're having it on April the 20th, which is 420. And it's going to be a time when people are going to be able to jump in, listen to what they want to, and then jump off, like Jan said earlier. I mean, this is a new age, man. We've got people, you know, they're not going to have to go to a stuffy old conference, sit down there and listen to a bunch of old parts like me, get there and talk. We're going to be able to jump on, listen to a session, and then jump off. So, I mean, to I guess we're not trying to educate people to pass the boards. What we're trying to do is bring them up to speed on the newest, the latest, and the greatest out there, which they don't always get on a CME regulated conference.
So I think one of the things that is probably very different is the business of residency
Mm-hmm.
and the business of trainees,
Yeah.
and how intertwined that is to societies, and
Mm-hmm.
how these societal based meetings almost obligate these trainees to have to be involved with some of these kind of older, more classic, for example, the SVS meeting.
Yeah.
And so there is probably a role, I think, healthy role for that, standing in a poster and your ability to show that. But I don't see that there's a long-term sustainability in the way that a lot of these newer generations are going to take information. And to Jan and Bob's point is, I've seen a lot of these guys get to third year and fourth year, and they can't even describe step by step how to do a renal stent, for example.
Yeah.
But they've had phenomenal abstracts published, right? And so there's this duality when it comes to fellows and residency about what they have to do to get through their lives, but there's then the need of finding information in a way that's easy, digestible, acceptable. And I think technology is going to help propagate this in a very massive way. And it's not only directed to Jan's point, it's not only directed to American based. I mean, we are at a level where our consumption is global.
Yeah.
And I think that's something very interesting of what this can do. But essentially, I guess I would like to hear your take on the relationship between the society meetings, the more classic society meetings, in this sort of meeting, in the type of content and the way that we think that we shall deliver a particularly different message of something that they may or may not, probably not, get at some of these more, older meetings.
Yeah, and can you especially dive into what the need is? What is the need that you're trying to fill with this type of conference, which I think it's real. I mean, I think we go to these conferences and we hear the same thing over and over again, and we don't get a lot of value. So where's the value proposition that you guys are presenting?
Okay, Bob, do you want me to take this one?
Go
ahead. Go ahead.
Yeah, you go ahead, man. You go ahead and start off, and then I'll just finish up when you're through a few of your thoughts.
I think each segment of medical education has its role, and live meetings are not going to go away, but I think they will evolve. But I think there's going to be a little bit less of them, and I think the bulk of medical education is already migrating into Instagram, Twitter, digital meetings, and so on. So specifically in our meetings, we really don't talk about data. None of us has to take our boards in the next year, but we simply want to help create strong operators. I remember historically when I was a fellow and I was able to afford to go to a meeting or two, the sessions I used to go to were complication sessions or some great saves. I just couldn't maybe withstand a session where some 5-year data on outcomes with some pill or a procedure is being presented. I just honestly wanted to be a good operator. So I looked at fun cases, and this is exactly how we're going to do it. We're going to show fun cases with new technologies, and then we all are going to argue. So, for example, I know that Miguel is presenting a lymph flow case. If you think, Miguel, that you're going to just present a lymph flow case and we all going to sit there and clap saying, oh, such a wonderful case, this is great, well, we may miss your expectations. Thank you.
No, so I mean, I can go back from the predecessor of this event, which was Icarus, and I know I presented a case, and I got attacked from about 4 angles. It was fun though, and I think the people that choose to tune in are going to be very excited, and they're going to be very happy with the back and forth banter that we're going to hopefully stimulate. And this is totally 100,000% unscripted. I mean, we're going to just off the cuff. Just we're going to put some people at we're going to make some uneasy people out there. I mean, we're going to ask questions that are not asked from the audience most of the time at some of these meetings.
I think you have been openly caught. you have been very forthcoming, both of you guys, about the nature of the discussion. Have you had any faculty say, guys, I don't like this? Both, but and this goes back to Icarus. Have you had anybody say, fuck this, I'm not coming back? This seems like auto mutilation. I'm not coming to this forum again. And what has been the response?
Okay. Well, nobody. I live in the south of the U.S. I'm in Birmingham, Alabama. So it's difficult to hear "fuck this" in this part of the country to begin, or so.
That's the beauty about podcasts, Jan. In podcasts, you can swear.
People, I know, people enjoy it. People enjoy it, and they like to get tough questions, both from the audience and from the chairman of the conference. So surprisingly, no. It's it's not like we are attacking anyone, but we'll challenge. Why did you do this? Why not something else? How do you support it with data, and so on? So no, the reception has been very positive. I would even say the reception has been more positive from speakers rather than audience. Audience too. But audience is unfortunately somewhat separated. We try to make it interactive, but there is also a cost issue. So all faculty members, love it. What we have encountered is that it's difficult to limit faculty members to only 7-8 minutes that we allow. So we had a request like, oh, please let me talk for 10 or 15 minutes because I can't really present in 10 or 8 minutes, and then we cringe a little bit, but you have to sometimes compromise. But there is a reason why we call the conference Endovascular Entertainment, because we really want this to be fun. Thank you.
But
no, and the thing is too, I'll just dovetail on that. We want people to be able, I mean, we don't need to have everybody come in and stay for the whole 9 hours or whatever we're going to be there. I mean, we're all going to be on a sports center type stage, kind of like, flashy. People can jump in and they, for a particular session if they like it. And then if they say, you know what, I'm not interested in venous stenting. So I'm going to, take a break and whatever. Then they come back into the next, part of the agenda. I think it's going to be really entertaining. And like Jan said, we are all colleagues here. We're not going to sit there and, personally attack somebody, but we might attack, them a little bit on what they presented and saying, why the hell would you not want to put a stent in a, femoral artery? Why wouldn't you want to stent across the, P2, P3 segment? Why, this is what we're going to say. And I think it should be said.
I think it's almost like a healthy poking holes, right? You want to have this multitude of perspectives that then brings some of the things, to Jan's point. Yeah, please attack the lymph flow, because I'm sure there will be a lot of people that say, well, why don't you do this aggressive pedal with bi-directional approach? And I'm going to turn around and say, because the patency of that shit sucks. And this other procedure has a better patency long-term, and that's the kind of stuff, not necessarily that I'm trying to in any way set the tone that this is a cussing event. No, this is our podcast. That's different. We're going to have a very respectful conversation, scientific. But what I think is cool is that it's purposely made to have a little bit of that edge that will keep people attached, that's going to break the routine of having everybody just applaud each other's presentation as if what you said was all absolutely perfect. And I think that there's going to be a lot more debate, and a healthy debate, right?
If I could encourage like some like thought and reflection on something, like when we talked to Frank Vieth, he mentioned like structuring his meeting and talks to a certain very limited amount of time.
Yep.
And I feel like that's old school in a way. And I would invite you guys to maybe try to break from that, because I feel like the real like juice of something, the real like nuance of information comes from more long form conversations and more long form discussions. So maybe instead of doing like one case or like one presentation every set, and whatever, it's your conference, do absolutely whatever you want. But
let me interject here.
Yeah.
Let me tell you the history, how we came up with this formula. So I was supposed to do a conference in Warsaw, Poland in May of 2020, and we all know what happened. So naturally, we were forced to go into a digital format. So we hired this media company out of Warsaw, and the guy running it, he was a former anchor of like main Polish evening news. And we started working together. And one day he came to me on Zoom and said, Jan, do you understand what business you're in? And I said, of course I understand. I'm in medical education business. And he said, you could not be more wrong about it. You're an entertainment business. You just talk about medical education. And that changed our thinking. And basically, the guy does like those digital conferences for gaming people. He has like, I don't know, 50,000 gamers coming on the conference, and they talk about some new games, and basically they try to keep people engaged every second of the conference. So we're trying to emulate. Thank you.
Yeah, and so let me just add on to, man, that you know what? We're going to start off with a 6 or 8 minute case presentation. You can throw a few statistics in there, but the real meat of the matter is going to come when all the participants in that session are brought on live. And then we have a podcast type of a formula like you guys have. I mean, I don't know if we can, fucking cuss or anything. I think we can probably get pretty damn close to it, and let's just rock some worlds, man. That's all I want to do. Let's make this entertaining, and let's make it. Hopefully, we'll get some people that tune in, and they'll get some education. They'll be brought up to date on the newest, the latest, and the greatest. But we'll also have some fun.
Hey, let me ask you a question from the business proposition standpoint. And this comes from a place where, as you both know, I've worked a lot of other territories, specifically Latin America. And when I do my business, in many ways, the financial support for the event when it comes to industry is siloed. If you think that we're siloed as specialties sometimes, industry is terribly siloed when it comes to geography. So when you come to propose to industry the business strategy for a global event, have you met a lot of resistance from where potentially there could be some support for this event? And do you think that we'll get to a point where we can have global budgets for meetings like this in the short future?
So Bob
That
Beasley is a master fundraiser, so I think he should answer this question.
Oh no, come on, man. Look, you know what? We all have our relationships with industry. We have really tried to get enough money from them so that we can, you know, become just just make ends meet on this one. I think if we make it work well, the money will come later down the
Yeah.
road for other Pegasuses. But right now, I mean, it's been tough this year. Jan's done. Well, I don't know. He's done just as much as I've done. I don't know why he wants to say that, but he's been out there. It has been tough because these guys. This is a new formula. They have no idea what's going to happen. It's all about the clicks. If we get the clicks and if we get the people that want to tune in, uh, and and want to become educated or entertained by this event, it'll continue. If we don't, then I'm afraid it probably won't. But that's why I'm encouraging all of the presenters and everybody that's involved with this event to let their cath lab folks, let their surgical, you know, OR folks, let everybody know that's in this world that hey, please turn us on, take a look at us, and help to hopefully let us propagate this to another level down the road.
Make-
Jan, you want to add more into it? I mean, Jan's been also very very influential in getting this off the ground.
Yeah, well, I mean, we'll cover looks like we will cover the costs of the conference, but nobody's gonna buy a car because we initiated it. I don't think we will even be able to afford a new tire for a car, but that's okay. That's perfectly okay. We do it because we feel this is the right thing to do. But I also have to tell you that fundraising for this event has been a little bit easier than previously for the conference that I co-ran out of Warsaw, Poland, because that comes under American budget for the industry. So a little bit easier.
Is there are you there's a cost for the attendees?
No, there is no cost for the attendees. You just need to register and preferably let everybody else know that the conference is happening. We really count on it.
So this is where I mean, for anybody that's been in the development of any educational courses throughout history, for anybody that thinks that there's a business behind it, you're absolutely mistaken. There's so much operational costs that go into this that a lot of times, I mean, I can remember more times than none, I have had to open my own financial account to pay for meetings in Latin America. And these are unfortunately, money losing things in many ways. Hopefully this one will not. But I know that there's an absolute commitment by all of us that this is going to be a success. And the fact that this is free, I think is ginormous, right? I mean, this is free education across the border. Obviously, production is expensive. High-speed internet is expensive. Flying speakers is expensive. And hosting the information for a return on investment that it's longer because those clicks may happen on that day. But what's infinite is that all that could be then nurtured throughout the rest of the year. Have you guys thought about, is this just a unique moment? Like if you're not logged in for the 8 or 9 hours of the event, you miss it? Or have you thought through, is there going to be the possibility of watching this on demand? I missed it. I was in the OR. I want to go back and watch it again. Thoughts on this? Because I think that there's huge opportunity also when it comes to clicks on allowing people to consume the information whenever they want.
Yes, the conference will be available for at least 90 or 180 days online for free. You will be able to watch all cases and discussions. But I want to reflect on what you said, Miguel, about industry support and difficulties and simply this business being difficult. I personally, if I was sitting in, I'm not going to name it, but if I was, I don't know, president or in management of a large endovascular company making devices, that would be my number one conference that I would support. And let me tell you why. We see huge discrepancies of care, of standard of care. You think that there is discrepancy of care between, let's say, Houston and South America. I bet that there is a huge discrepancy of care between East Houston and West Houston. And even in the place where I am, in Birmingham, Alabama, I'm not going to name hospitals, but let's take as an example treatment of SFA disease, chronic total occlusion. If you come to one hospital with occluded SFA, there is a 95% chance that this will be repaired by endovascular means. If you go to a hospital across town, large hospital, there is a 95% chance that you're going to get FEMPOP bypass surgery. You would not believe how standard of care doesn't exist. It really comes down to operator skills. Like one hospital has really no history of training their operators in endovascular therapies. The first hospital doesn't have a lot of really surgeons who are enthusiastic about operating. That's a fact, and that's a large city in the middle of the U.S. So for the industry, I think the really huge benefit is to train people how to do difficult cases, and at the end of the day, use their equipment. Thank you.
I think
Yes,
what you
Jan,
just said, yeah. No, I think what
I'm
you
sorry.
just
I
said,
just want to add.
yeah. Go
I
ahead.
just want to add a little bit more. 1 second here. I just wanted to add a sec. The production, the studios, and we were very fortunate to have HMP to be involved with us to do the production and to help us with the studio management and you know the whole you know going back and forth with the cameras and the set person and all that kind of stuff. So I think this is going to be a really nice production, and it's going to be done very professionally and very very well done. So I'm sorry to jump right back into that, but it was I just wanted to give the kudos. I mean that's where that's where a lot of our um, spend, if you will, is going to go into production. So this is not going to be a just a hopefully it's not going to be something that's sort of willy-nilly. It's going to be well produced. So
Yeah,
sorry
back
about jumping in.
yeah, back to where
Yeah.
you were saying, Jan. I think what you just said, I think speaks a lot to the need that needs to be filled, which is that you have one hospital that does bypass, a lot of bypass, and you have one hospital that does a lot of difficult crosses. Probably the right solution somewhere in the middle. Not every difficult cross needs to be crossed at all. I think the need is to be able to have that conversation and be able to parse that out, because obviously we have conflicting data that people are on one side of the aisle and other side of the aisle. The truth is somewhere in the middle, and the truth is going to come out, and we're going to come out as a group of people. We have to see ourselves as a group of healthcare professionals that are treating the same population. So interventional cardiologists, vascular surgeons, interventional radiologists, we kind of have to communicate to ultimately benefit the patient, which is at the end of the day, all the devices, all the techniques, everything else, at the end of the day, our goal is the same, is to have a good outcome for that patient. So I wonder how you're going to promote that conversation between the person that does and believes strongly in open bypass and has some very good arguments for them, and the person that believes strongly in the vascular, first approach. How are you going to promote that that coming together of ideas?
I don't necessarily
Well,
think
we'll argue.
that
We will argue live about it. That's what the conference is all about. We want to hear all voices.
I don't, Lucas, I don't necessarily think I don't necessarily think any of the course directors have a moral,
It's not moral.
a moral authority nor a moral obligation to help anybody decide what they need to do. I think what we want to do is show. It's very simple. We're bringing education in a different way. 2, we're all from different specialties.
Mm-hmm.
And 3, we can take our gloves off and we can go hard at it with data points,
Mm-hmm.
with technological points, and come out fortified, strengths from a respectful standpoint, where we're not necessarily falling into this dumb rhetoric.
Well, either you believe in standard of care or not, because I think Jan's point was a great point, which is like there is no standard of care. There's a lot of disparity of care. A lot of people get amputations without an angiogram, which is something one of our previous guests mentioned, and I think that's apparent. But I feel like that's how we need to advance a conversation. It's like, how can we come together and kind of agree in some basic things, and then when you design educational conferences, then how do you structure them so that those conversations are had, so that we can have some degree of standard of care? I don't know.
Let me just interject. I'm at a conference right now. I was at a lecture this morning. I heard a vascular surgeon present a series of about 150 patients that he had treated with, and I should probably name the device, but it's like, it's by Gore.
Yeah.
It's VBX. And I'm an OBL, and I work. I can't keep a long list of Viabons on the shelf, because if they do go, if I ever have like a complication with an external iliac or a common femoral or something like that, they these things expire, and so you can't keep the whole list. This guy has been doing work at this hospital in New Jersey, and he keeps a 7 by 39 and a 7 by 59
Mm-hmm.
VBX on the shelf, and he takes it down. This is what freaked me out. He takes it down into the common femoral, and they've done about 80 or 90 cases in the common femoral, all the way down to where the profunda and the SFA bifurcates, and they have not had any kinking or closures or anything on this. That changed my whole thought about this, and that's why, we were taught for so long, don't even touch the common femoral with a stent. And now things are changing. And this is what I think we're going to be bringing forth with our conference.
I think the fact of the matter is the siloed meetings and societal politics can go and implode on themselves. I have absolutely no interest in being part of it.
Mm-hmm.
I don't want to be sucked into the political rhetoric. I don't support the political rhetoric. And I want to be part of something that is building and not destroying.
Yeah.
And it feels to me like lately a lot of our leaders, thought leaders, key opinion leaders, call them whatever you want, are distracted by publications, by the media, by all these other things, and we forgot about just healthy discussion, professional, reasonable, responsible, data, technologically driven discussions where we can have these really strong opinions, contrarian opinions, but that we come out fortified and strengthened by now new education, by a new perspective, by a new thought. To your point, Bob, stenting with a VVX to common femoral sounds like a sinful thing to do, but having the discussion in a forum that allows you to have it is probably better than not talking about it and just crucifying some dude that came up with that idea.
Yeah.
Because that's how you change lives. You have to stop being afraid of being able to say things, and you have to be able to have responsible clinical research and outcomes. And I'm not saying go ahead and be a cowboy. No. But come on, let's talk about this without throwing missiles at each other. That makes no sense.
So Miguel, that's the dilemma that we actually faced preparing the conference. Like, where do you stop in terms of the controversy? so last year was kind of interesting for endovascular community, because if you remember from July, one of our esteemed colleagues found himself on the front page of New York Times
Of the Times, yeah.
with 7 or 8 pages investigative editorial in New York Times. I actually wanted to interview this journalist from New York, and to tell you the truth, I reached out to her. Well, how about having an interview live on our conference? She declined. I don't know why a New York Times reporter would decline an interview regarding her own article, but she did. So we're not doing it. But I wouldn't be opposed to, to discuss controversial issues like this. But
we
at some point, you stop.
are going to also have the doctor she tried to expose, and I think just just without any type of evidence, and the evidence that was presented was just, in my opinion, was just it was a hit job. So we're going to have this doctor on with us, and we're going to probably broach the subject during that session.
But not with an intent to make it a sensational thing, right? I mean, I don't necessarily think that our intention to bring that is to get more clicks, because it's
a learning opportunity.
Exactly. And you and I have talked about this, right? I mean, Lucas and I have talked about having all these people come, and you would be surprised that you would think a lot of people would just jump the gun at the opportunity to come and have a live conversation. But all of a sudden, it's crickets, man. When we say to an invitation, hey, come for an hour and talk about.
Well, we haven't sent an invitation to
we have some,
reporter.
and some have not come back.
Yeah.
But we haven't to the reporter, which may be an interesting spin. I guess we were targeting only the physicians involved.
Yeah.
But why shouldn't we just bring the reporter to have a conversation with us?
Yeah. I mean, if we're going to talk about it, let's talk about it. I mean, I think that there is a case that there is overuse. Or specifically atherectomy. And I think that as a community, that's something that we need to broach, and we need to have in these forums, because it hurts all of us. And the thing is, there is a space for atherectomy, but it's not probably 98% of the time. So we have to broach these topics, and we can't just say, oh, it's a hit job, and then just put our heads in the sand and just say no. Obviously, this is a person that's highly respected, this operator, so this doctor. So I'm not saying that it's a specific thing on this person, but as a community, and I've seen this in the community that I practice, there is an overuse of these type of techniques for profit, and I've seen it. So we have to address it, because if not, somebody's going to address it for us. So I don't know. What do you guys think about that?
It's being addressed right now. I think CMS, is pushing. I'm in the OBL ASC setting. Everything's being pushed to the ASC, and I think it should be with more oversight. Not everybody needs to have atherectomy. In my outpatient labs, we do not. We don't even approach 90%. I mean, 80%, 75%, whatever. If it can be treated as a value-based medicine practice, which you're seeing more and more of that being pushed by the insurance companies as well, then that's the way we do it. I mean, we will absolutely use atherectomy on calcified vessels, but if you have, say soft plaque or whatever, you can do a balloon angioplasty and put in a drug-eluting stent, then we do that, and I think that's appropriate, and I think more the insurance companies are being, they're educated as to what's being done out there. Anybody that does 98% atherectomy on every, I think, lower extremity, either SFA or tibial case, is just looking to get, pretty much shot out of the saddle, in my opinion.
So I don't want to raise an issue of atherectomy, and I think medical conference is much more proper forum for this than a podcast. What I would like to say, that after reading this article in the summer, parts of it definitely felt like a hit job. parts of it, there were some legitimate questions asked about particular devices being used and strong industry support for OBLs. But I do want to remind you that as citizens of this country, investigative reporting has been the cornerstone of democracy here.
Mm-hmm.
And unfortunately, we see it less than we did 20 or 30 years ago. And I just want to remind you that if not for the investigative reporting, there would not be a Watergate scandal in 1972. So in a way, I admire New York Times in general for keeping their staff dedicated to investigative reporting in the society on any important issue. Thank you.
I guess the problem is gravitating towards a person that has had a track record of pursuing education, of excellence in the care of patients that don't have a lot of options. And I will say, if somebody wants to do a hit piece on me, which by all means, go ahead. It's not like I have a whole lot left. But you're going to find out that I probably have one of the highest major amputation rates of the Houston Medical Center.
Yeah.
You know why? Because every disaster and every no option CLTI patient now comes my way. And not everybody, I mean, I can't do miracles, man. I'm a doctor. And so if you just look at my numbers, somebody would be like, well, Montero's a hack, right? I mean, he's talking all this game, but he's doing all these things. And I just feel it's unfortunate. And to your point, I do agree. You know, I think, hey, First Amendment, free speech, whatever you want to call it, but what saddens me about the whole story is, and this is hearsay, that it was apparently, it came from physicians trying to start this, that were inviting the New York Times in to look into this matter. And
I heard that too.
and this is after the medical board had already passed judgment multiple times in situations without any punitive damage. And so why are we as physicians removing ourselves from the discussion platform and bringing upon journalism with an uneducated, unpolished, unsophisticated, and ignorant perspective, mix and matching claudication with critical limb ischemia or chronic limb-threatening ischemia, two very different disease conditions, talking about atherectomy with no real understanding. I mean, it was very, very confusing. And the problem is that the few times that people talk about PAD to the world is this.
Well,
and
that's
not
on
through
us. That's on us.
Well,
That's on us because
it's not
we
sexy,
have to,
man. I mean,
well,
everybody knows what breast cancer awareness is. It's sexy. It's cool. There's pink bands. Everybody knows it. There's people walking the streets all day. Stop anybody and ask them what PAD is. And it's not about me, man. I'd go and walk tomorrow every day.
I think a lot of patients know that
There's no
diabetes
political
equals amputation. I think that's very out there in the.
I don't think so.
In the,
There's no political agenda. There's no political agenda to help us. Anaida Dua said it in our podcast. Unless we have people in Washington making it an issue, a true issue, to bring notoriety to this problem, and unless we have enough government funds to understand it and to create, it's going to be very hard for us to create a path forward. But I believe that maybe for us, at least at this micro environment, doing this sort of events, open discussion, responsible, reasonable, I think it's a good way forward. Yeah. It's better than taking it to the press. Guys.
Okay. So two comments. I don't exactly understand, Miguel, what you're saying, but I will respond anyway. Hopefully there is no hit on you, but I can tell you two things. That number one, being where I am in Alabama, again, I see huge discrepancy of care, and if believe it or not, if you're an internal medicine physician and you want to open an OBL and start doing procedures, You're perfectly fine to do it, and we have examples of such practices in the state. I am not kidding.
Really?
The second comment I can offer is that society in different geographical or political segments polices itself differently. What happened in the state of New York about 10 years ago, there was mandated reporting of outcomes of patients undergoing heart surgery. So obviously, the better surgeons get the sicker population and sicker patients. So naturally, their complication rate is probably 3 times higher than surgeons who just do regular low risk bypasses. So what happened in the society in New York, surgeons on day one, they basically stopped taking difficult cases. And they declined a lot of patients that they wouldn't have declined before. So who benefited? Well, Cleveland Clinic benefited, but because all the New Yorkers with advanced heart disease were going to Cleveland Clinic to have high-risk surgery. So, every action has a reaction. Thank you.
Well, I just want to also say, in response to Miguel, that there's there's a lot of tense remarks out there about what was going on with the New York Times article, and I think you succinctly put it together, Miguel, by saying that the folks that try to treat the worst patients, like you and the physician that was chronicled in the New York Times article, are the ones that sometimes get blown out there in front of everyone. And it's unfortunate, but unless we have the ambassadors like you guys to take care of these folks, no one else will. And there's not going to be another way that we can get to the next level without this. So I'm hopeful that with Pegasus, that we'll open some eyes, that we'll have people ask questions about why not do it this way, why not do it that way, and we'll see some of the world's most, unique devices and treatment strategies come to bear. And I hope we can promote this, and with you guys with your help, Lucas and Miguel, I think hopefully we'll have some success in this regard.
Yeah, I agree with Bob, and we came on the podcast in order to tell you and indirectly promote our conference. Now we are promoting New York Times subscription. So let's revert back to Pegasus Endovascular.
Well, I was just going to say,
great conference.
Jan, Bob understood my thought very clearly, and I thought it was really well articulated. But
I'll raise my Polish. I will raise my Polish flag.
We'll have to. You know what? We'll have to discuss this at Pegasus. Okay, we'll continue that conversation.
We will.
Listen, guys, I know that you're all busy. This is the weekend, and you've carved time to come and share with us here at the Life of Flow podcast. I do dearly appreciate you two are my good friends, my colleagues, mentors. And I look forward to a phenomenal meeting soon next month. Pegasus. We're going to make sure that we...
Pegasus?
Yeah, Pegasus. I tried to give it my Latin.
Speaking Greek.
This is
Pegasus. Oh, okay.
Pegasus is my Latino. Is it Latino? We are going to make sure that we produce and we pop this podcast out very early on so that we can give.
When is it again?
It's going to be
April the 20th on Saturday. Okay. The whole day of endovascular entertainment. So join.
It's going to be
Google.
I'm going to go get some popcorn.
All right, guys. Thank you very much. Any last thoughts, Jan? Any last comments or thoughts before we let you guys go?
Yes. Join us on April the 20th. Google Pegasus Endovascular. It will come up. Free registration. Encourage your colleagues and friends. Vascular surgeons, interventional cardiologists, angiologists, and interventional radiologists, and all the cath lab staff. It will be fun. Even if you don't stay the whole day, attend some sessions.
Guys, thank you very much. Y'all have a beautiful day.
Thank you.
And we'll be in touch. Pura vida.
Yep.
All right, we know who lives in Florida.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.